Hello, everyone. Welcome to the webinar. I'm Shanta Jackson. We'll give everyone a few more minutes to log in some of the other attendees. It is 1 p.m. Eastern on the dot. Actually, Peggy and Alisa, if you could join in, that would be great so the attendees can have the opportunity to see who you are. I think you're on mute.
Hello.
Hi, Alisa. Hi, Peggy. How are you today?
Good. How are you?
Good, good. Thank you. Hello, everyone in the audience. You should, while we're waiting, play around with your panel. There's a chat feature and then there's a question box, and we will try our best to answer any questions throughout the webinar, but I'll give you more instructions as when we begin. Peggy and Alisa, we have 37 attendees on the line right now.
Great.
Great. Yes, yes, yes. Okay. So what we'll do is we'll go ahead and start with the webinar. And again, everyone, my name is Shanta Jackson. I'm the Chief Executive of Cause Engagement Associates. And today we have our two guest speakers. We have Alisa Howard. She's calling in from Las Vegas. And we have Peggy Hogarty. And Peggy is calling in from Boston. And I am in the Metro Washington, D.C., Baltimore area. So thank you, everyone, for joining in. We'll actually take ourselves off of the camera and we'll get started with the webinar. Okay, great. So again, everyone, welcome. Thank you for joining Cause Engagement Associates 2019 first quarter webinar, working with community health workers to eliminate health disparities and build healthier communities. I am Shanta Jackson, founder and chief executive of Cause Engagement Associates, your moderator for today. Cause Engagement Associates' purpose for hosting this webinar is to provide a platform for our peers to share their resources, lessons learned, and recommendations to help make a greater impact in care, service, and the field of chronic disease prevention and health promotion. Today's webinar is approved for CHES and MCHES, continuing education contact hours in health education. If you are an active CHES or MCHES, you will be required to participate in the entire live webinar and complete the evaluation survey no later than 5 p.m. Eastern Standard Time on Monday, March 25th. 1 hour after the webinar, all attendees will receive an email with a link to a short evaluation survey. It should take no longer than 5 minutes. And we welcome and appreciate everyone's feedback. A link to the evaluation survey is also available on our website, causeengagement.com. Simply click on the tab labeled Webinars. Before we get to our guest presenters, I'd like to go over a few logistics. To the right of your control panel, there's a button to expand and minimize your panel, and a tab where you can type any questions to us during the webinar. Per the request of the presenters, each presenter will answer questions after their presentation. Also, be sure to download the handouts provided by our speakers. And before we get to the speakers, one thing I would like to know, I have a little poll. I'd like to know which best describes your industry. We just like to get an idea of who we're presenting to. And Alisa and Peggy, FYI, we have 44 attendees as of now. I'll give you 5 more seconds to respond to the poll question. Okay. We have Alisa and Peggy. Can you see the screen? Okay, so we have, I can't hear you, Alisa and Peggy.
Yes, we can.
Okay, perfect. So we have majority public health, and then we have healthcare, and we have some in academia, and a small percentage in nonprofit, in the nonprofit arena. Thank you very, very much. And then I have one more question for you all. If you could please tell us about your relationship with community health workers. Okay, I'll give you 5 more seconds. Okay, great. So for all of the attendees, these are your peers on the call. The majority are community health workers. And then we have the next greater response are individuals who say that they have an existing community health worker program and they are looking to expand or improve it. And welcome to the students. And we have some community health worker supervisors I see, and we have individuals who are interested in developing a community health worker program, which you can also you can always reach out to Alisa. She'll have her contact information at the end of the slides, or you can reach out to Peggy, or of course you can contact Cause Engagement Associates as well. So thank you very much for that. Okay. So our first speaker is Alisa Howard. Alisa is an associate consultant with Cause Engagement Associates and the owner of Minority Health Consultants, which she started in 2018 as a result of her witnessing health inequity, inequality, and disparities occurring in communities of colors not being addressed. Alisa is also a community health worker instructor at the College of Southern Nevada. For the past 8 years, she has worked in public health on multiple levels of society and with various types of organizations, which includes the State of Nevada's Tuberculosis Elimination Program, county level government work in HIV and STD surveillance, and with the sexual health clinic at the Southern Nevada Health District, and most recently at the community-based organizational level as the director of the first Ryan White Part B HIV prevention program and an early intervention program at the Las Vegas Urban League. Alisa is also a former also a former board member of the Urban Coalition for HIV/AIDS Prevention Services. And locally, she is the first vice chair for the advisory board of the Teen Pregnancy Prevention Program at the Southern Nevada Health District, as well as a member of the Nevada Primary Health and Equity Coalition and the Nevada Community Health Worker Association. Everyone, please welcome Alisa Howard.
Hi, everyone. Okay, so I wanted to jump right in. On the screen, you should see where we have the terms that we're going to talk about today.
Actually, I gave you the mouse, and you should be able, we're still on your intro slide.
Perfect. There's a slight delay with the mouse.
Okay, go ahead. I have you. So I have terms.
Okay, here we are. So the terms that we're going to talk about today are community health worker. What is a community health worker? It's a frontline public health worker who builds individual and community capacity by increasing health knowledge and self-sufficiency through a range of activities such as outreach, community education, informal counseling, social support, and advocacy. By the American Public Association. And then the cultural competence is a congruent set of behaviors, attitudes, and policies that come together in a system, agency, or among professionals, and enables the system, agency, or those professionals to work effectively in cross-cultural situations. Slight lag in the, there we go. And cultural responsiveness is what we'll talk about today as well. So like the term cultural competence promotes, this cultural responsiveness promotes, an understanding of culture, ethnicity, and language. The difference between the two is that responsiveness does not imply that one can be perfect and have obtained all the skills and views needed to work with culturally diverse clients. It assumes one just has the openness to adapt to the cultural needs of those whom they work with. So let's look at the model for culturally responsive leadership. A lot of people don't understand the model for this. So basically this model includes inclusive work environments and practices. It also includes, this particular slide is important to agencies and public health departments who are responsible for training, managing, and leading community health workers. And basically, in order to have an effective and cohesive community health worker workforce, it is important to be intentional about providing an inclusive work environment and practices. When it comes to your values, practices, and policies, it's important to incorporate the background, values, and cultural knowledge of your community health workers as well. So some of the things that we need to be asking ourselves as managers, administrators of programs, but also as CHWs, are we culturally responsive? Have we been trained to work with diverse populations? Are we hiring professionals that look like the community you are serving or trying to reach? If not, ask yourself, why not? Is there a lack of diverse people entering the public health field? If that's the case, how can we as program directors, managers, administrators, etc., implement new policies and practices to improve the recruitment of such diverse people for our organizations? And then lastly, are we culturally connected? Meaning not only do we look like the population, but do we identify with that population? Can you relate? Do you speak the lingo? Do you understand the culture? Just because you may look like the culture that you're serving does not mean that you understand maybe the possible lingo that they're speaking, or things that may be going on in that culture that maybe you're not up to date with. So those are questions that we need to kind of ask ourselves. There we go. And so some of these things we need to address when working with our HIV clients. This is for HIV agencies. In particular, I'm going to speak to that. Social determinants of health. This is the social determinants of health model. And basically, these are the barriers that stop us from being competent to work with our HIV clients, because we're not addressing the whole person. So social determinants of health basically includes economic stability. And I'm sure a lot of you have seen this, but are we applying it to HIV agencies? Are we helping people with HIV with employment? Are we helping them with income, how to get more income, expenses, their debt, medical bills, support? And what I mean by this, are we tackling these determinants of health with our clients when we sit down and do their assessments, when we do case management with them? But also the neighborhood and physical environment. Maybe they're not being housed right now. So if they're not being housed, how can we make sure that they're taking their medicine on time, taking it every day, taking it so that they can be virally suppressed? Are we addressing their transportation issues? How are they getting to and from your offices? Any safety concerns that they may have? All of these things play a huge part in addressing HIV, clients with HIV, and helping them to become virally suppressed and living the best life that they can. Also, education. Are we addressing, maybe possibly they want to get into community health work. Maybe they want to expand their knowledge and their education. Do they have their GEDs? Which will go back to the economic stability, because maybe there's a reason why there's an economic stability, because they don't feel like they have the education needed. But also food. So food is a major barrier to a lot of clients that I worked with in HIV. Just simply being hungry and having access to healthy options. We know that as we work with people with HIV, their immune systems are already compromised. So are we allowing them to have access to healthy options and telling them what those healthy options are? But also community and social context. So are we engaging them? Are we just serving them, but are we also engaging them? Are we addressing discrimination and stress that they may be feeling? I've had a lot of clients come to me when I worked at the Urban League and say they felt discriminated against by other, hospitals or other case managers in the community or something of that nature, not knowing that that was a barrier to the reason why they weren't coming and getting their medicine, or not signing up to get their medicine because they just didn't want to deal with the system in its entirety. But also the healthcare system, that kind of goes right into that. Are we being culturally competent as providers? Are we being culturally responsive? Are we making sure they do have health coverage, whether it's Ryan White Parts A, B, or C, or D? Are we making sure that they're covered by Medicaid? Are we making sure that basically we're being linguistically and culturally competent when working with certain diverse populations? And then the quality of care that we're giving them, that's very important. So addressing the client's whole needs, food, housing, childcare. What if they can get a job? So maybe now we've hooked them up with another nonprofit organization that can help them get employment, but now they have a childcare issue. Are we making sure that we as providers, but also community health workers and case managers, are we addressing all of the clients' needs and all of their barriers that they have, medical wise, mental health? Are we addressing their mental health issues? Whether they tell us something in private or whether we see something, are we addressing those issues? Substance abuse, domestic violence. Some people may not be safe in the home that they're currently living in. Are we listening for those cues and being responsive with those cues? Education and utility assistance. So do we know the resources basically to send a person with HIV to get help with all of these issues? If our agencies that we work for currently do not do any of these things besides the case management of people living with HIV, then are we being responsible enough to send them to agencies who do take care of these issues? So you may ask, why community health workers? What's the difference between a community health worker and me just hiring someone if you're a person that is an administrator? Well, basically, community health workers, they help with healthcare costs. They save tons of money for the state. I know from research that for Nevada, so far our community health worker program, I believe it's been in effect for about 3 years, has saved the state a ton of money in just working with Medicaid in general, and not, so basically community health workers, basically they help so that clients do not go to the ER all the time. So that's how healthcare costs are saved. It's saving the state money, it's saving the state Medicaid money, and basically these healthcare costs just continue to rise. The CHW role is one of the potential solutions for U.S. healthcare systems. The current nursing shortage and projected physician shortage, which for HIV providers means less infectious disease specialists. Not sure if you guys, where you are and what state you might be in, but here in Nevada, we do have a nursing and physician shortage. Also, CHWs bridge the gap between communities because of those other reasons in the other slides that I mentioned, being culturally competent, being from that community, being peer navigators. The health and basically, and they bridge the gaps between the health and social service systems. What they do is they connect people that are living with some type of health chronic disease with the social services that meet the other barriers that they may need. And basically a recent focus on racial and ethnic disparities in health outcomes is why community health workers are a great choice. So how can CHWs help? Well, I mentioned a couple of...
I'm sorry. And also, it's a question also for the audience. In addition to, I apologize, Alisa, for interrupting you, but this is also an opportunity for the audience to provide feedback in the chat box, please. Continue, Alisa. I'm sorry.
Oh, no problem. So how can CHWs help? As soon as this goes. So just basically some of the things that I've already stated, but also community health workers can provide care. Care can be provided in the home by the community health worker. Meaning I have a couple of students that have gone to work for the health district here, and they actually go to the actual client's house. Why does that help? Because some clients their chronic disease is so bad that they can't always go to a doctor's office. So being able to go to a client's home provides a lot of help for them. Shanta, I'm not sure why this slide is not going.
Okay. So let's see what some of the audience members says. How can community health workers work? Myra, I believe, says supporting getting people into care, into a system of care. And then Carmen says people need to have information on how to treat their sickness. Education is key. And then to better integrate people who need health with the services such as federally qualified health centers as well. So thank you all for your responses.
Absolutely. There we go. All right, and also community health workers can help educate community members about how to use the healthcare and social service systems. A lot of people would be very surprised that this is not a common thing. A lot of people get healthcare insurance or get Medicaid and don't understand how to use it, and also the social service systems, where to go for those barriers, right? What agencies help with certain things. They can also provide information and awareness on various topics regarding health and wellness, and support clients in accessing quality healthcare and social service programs, just to name a few. They also support primary healthcare prevention and control of chronic disease among underserved populations. They can enhance care quality by aiding communication between the provider and the patient. That is one of the largest things that I've been able to see that have been very effective. A lot of clients don't know how to basically ask their provider questions or what questions they should ask. And so that community health worker could be there to help that client. And just a few other things. So we're going to jump right into the spectrum of prevention. So basically the spectrum of prevention is a resource for understanding the range of strategies that CHWs may use to promote the health of clients and communities. And just speaking from an HIV point of view, people living with HIV can help influence policy and legislation. I'm working with a group right now that is actually working on Nevada's law as far as HIV criminalization, and they're working in the policy level. They may not have gone to school for that, but they're being trained, and they're taking trainings and by local policy members and legislative members to basically help in this area. They can also change organizational practices. So bringing in a community health worker that's also a peer navigator in a community health worker aspect can help change your organization's practices and how you all work with the community. And educating providers is another big one. Fostering coalitions and networks. So there is a Southern Nevada HIV coalition here, and I'm sure wherever you are, whatever state you may be in, there's several of those there as well. So as you can see, just from the spectrum of prevention, community health workers can help in every area in the spectrum. And then this slide just basically goes towards the 8 dimensions of wellness. So it kind of goes in line with the social determinants of health. Are we helping a person holistically? Are we helping a person living with HIV emotionally? Are we helping them with their environment, their finances, their intellect, that goes back to education, their occupation, their physical needs, their social needs, and their spiritual needs? If we're not tackling all of these dimensions of wellness, pretty much we're not helping the client on the full level that they deserve to be helped on. And I don't want to exceed my time. So I'm going to go ahead and open it up for questions. I do thank you for listening to this, and my contact information is on this slide. If you need help with implementation of a community health worker program, or you have community health workers and they need specific training for your program, please give me a call or email.
Alisa, we have A question from Nana. For the spectrum of prevention, is there a correct order, bottom up or top down?
No, so the spectrum of prevention is pretty much just a spectrum just to show you a full range of how an actual community health worker could help in these areas.
Okay. Does anyone else have any questions? If so, please enter them in the questions area or the chat box. Yes, we have one question let's see, we have a question from Lana. How does the spectrum of prevention and the wellness model interconnect?
So the spectrum of prevention and the wellness model, pretty much it basically connects because, as I stated, it's holistic, right? We want to help a person on a holistic standpoint, not just addressing their actual chronic disease, but addressing all of the elements that affect an entire person. And so if you look at the emotional aspect on the wellness model and the financial perspective, and then look back at the spectrum of prevention, you can look to see where does that fit in? How can I address my clients' emotional and financial needs by helping them get involved in one of these areas on the spectrum? So if it's a community health worker, are we training them to basically educate providers to be that resource or that expert in that particular area? And if it's a client that we're working with, are we training them? So are we tapping into their intellect on the wellness model so that they can educate their provider? That's just an example.
Perfect. Thank you very much for that comprehensive response. And we'll move on to our next presenter. But before we do, this is Alisa's contact information. Again, she's located in Las Vegas, Nevada, and she is a community health worker consultant and trainer. And our next speaker is Peggy Hogarty. Ms. Hogarty is the program director of the Community Health Education Center for the Boston Public Health Commission. She has extensive experience in designing and delivering core competency and specialized training programs and curricula for community health workers and their supervisors, including curricula on chronic conditions in the areas of asthma, diabetes, and cardiovascular disease and prevention. Peggy has also been involved in the state of Massachusetts community health worker policy and workforce-related efforts. She co-chaired the Workforce and Training Work Group of the legislatively mandated Community Health Worker Advisory Board, with recommendations published in the Community Health Workers in Massachusetts Improving Healthcare and Public Health Reports. Currently, Peggy serves on the Massachusetts Department of Health's Board of Certification of Community Health Workers, providing input related to the development of community health worker training and certification standards. She also co-chairs on the advisory board of the Massachusetts Association of Community Health Workers, a statewide professional organization for community health workers. And at this time, I will hand it over to Peggy.
Good afternoon, everyone. I just want to talk to you a little bit about, I'm trying to see if I can, whoops. Uh-oh. I lost my, okay. I want to talk to you a little bit about who we are. So CHEC is a program of the Boston Public Health Commission. We're the city public health department for the city of Boston. And we've been around since 1993, we're in our 26th year. CHEC provides high quality, comprehensive, affordable training and professional development to community health workers and their supervisors. Our mission is to build CHWs' capacity to deliver health education, advocacy, and referral services to community residents. And we've been recognized nationally as a model program for CHW training. Just trying to see if I can. So who we serve. Last year, we trained about 540 CHWs and their supervisors on a variety of topics, such as asthma, diabetes, substance abuse, mental health, adolescent health, behavioral change methods, supervision, and training and design delivery, to name a few. Of that, 70 community health workers completed CHEC's 80-hour core competency training program, which meets the Massachusetts state requirements for certification of CHWs. The 540 CHWs and their supervisors came from about 80 organizations. We serve a wide variety of community partner organizations, including community health centers, hospitals, community-based organizations, public health departments, housing authorities, immigrant and refugee associations, city and state agencies, and faith-based organizations. So I'm going to talk to you now. We do a lot of different training and professional development events, but I'm going to talk to you about our CHW core competency training, which is entitled the Comprehensive Outreach Education Certificate Program, or COEC. We offer the core competency training 3 times a year, fall, winter, and spring. And the completion requirements for this training is 80 hours of training, which breaks down to about 64 hours of core competencies and 16 hours of health knowledge topics. And this is the requirement for, again, training requirement for state certification here. The core competency curriculum is 13 sessions, and everybody's required in the training to take those sessions. And then we have electives, which we call health modules. And the CHWs in the program have to take a minimum of 16 hours of health module training. I wanted to say that the length of the training works out to be about 2.5 months. We offer the core competency trainings about twice a week. And we only really train CHWs who are working in the field. So this allows the CHWs to work and take the training at the same time without losing too much work time or falling behind in their work. Also, the structure of the training, attending trainings twice a week, helps CHWs with the learning process, particularly with retaining the knowledge and skills that they're learning in the training. And then they can immediately practice or apply these skills in their workplace. So the core competency sessions, the training covers 10 CHW core competencies that CHWs are required to know for state certification, and they're listed here. These core competencies, like I mentioned, are covered in 13 sessions. And the first session is comprised of a half-an-hour orientation to the program, and then the leadership development session, and the first part of outreach methods and strategies. And then the other session that is 2 sessions is documentation, and there are 2 half-day sessions just because it's kind of a tough topic to get through in a full day. But the rest of its sessions are full day, and our full day is 9:30 to 4. We found that CHW's attention kind of flagged in the afternoon, particularly when the sessions, we tried 4:30, and so then we cut back to 4 with a 45-minute break. And this gets us to the 64 hours of training time required for state certification. We found that the structure and the length help CHWs complete the training. Some training programs meet once a week, which it gives more opportunity for folks to miss sessions. I'm going to talk about that in a minute, and has a harder time in completing the sessions. So this was a good pace, I think, for CHWs to attend the training and complete the training. It takes a second in changing the slide. So the second part is the training focuses on health knowledge content, and the overall goal of this health module part of the training of the curriculum is to increase CHW's proficiency in health-related information and referrals on a range of health issues affecting community residents. We offer about 10 health modules per COEC training program, and we rotate these modules over the course of the 3 training programs we offer. And some are 3-hour half-day sessions or 5-hour full-day sessions. And CHWs who can also take health module trainings who aren't enrolled in the COEC program. So if they complete the COEC program, but they see something that they want to take that they didn't take during the program, they can come back and take that training. So I want to talk a little bit about the key elements of the CHW training. This particular one is training approaches and methods. So our training is rooted in adult learning principles, which draw on CHW's strengths and experiences, validates their knowledge, and encourages peer support. CHWs bring years of experience living and working in the communities, and none of this sort of community knowledge base is in textbooks. It's experimental in nature, and the folks that are newer, the CHWs that are newer to the field, learn a lot from the CHWs who've been working in the field. So this creates a very empowering learning experience for everyone. The training is highly participatory, so that each session is interspersed with small group activities with the presenting of the information and concepts. So we encourage the trainers to create a variety of group activities such as case scenarios, role plays, small group problem solving. The class size is kept small. We accept a maximum of 25 CHWs per program, and this again gives a chance for the CHWs to participate and practice skills in the training. So the other thing with the adult learning methods is by presenting information and then creating a group activity or an interactive activity, they can apply this new information to real work situations. The health knowledge part of the training, we encourage cross-training. So this enables CHWs to respond to the complex needs of their clients with some basic knowledge, information, and referral sources. I think Alisa in her presentation talked about addressing holistically the client's needs. And like I said, the health modules are electives, and no matter the CHWs, the top 3 health modules that they pick are substance abuse, domestic violence, and mental health, no matter what population they're working with or what health topic they're working on. The training, the training also, we try and promote networking among the CHWs to share information on resources in the community, as well as provide peer support among the CHWs. They come from different agencies. They're either working on similar or different populations or health issues. And what occurs in the training is it brings together CHWs who are engaged in similar work and can build a strong peer support group through that training. What we encourage folks to do, we have a contact list that we pass out at the beginning of everybody who's participating in the training, and we encourage them to be in touch with each other during the training and after the training. We also, to create networking with a variety with CHWs from various agencies, we try and limit the CHWs to 3 CHWs per organization who can participate. So we get questions about how do we recruit CHWs, and one of the biggest challenges is also completion. So I'm going to talk a little bit about that. So we've been around for a long time, like I said, 26 years. So we have an email distribution list of 3,500 CHWs and their supervisors or managers. So we send out our training flyers and announcements through that email distribution list. We also promote our trainings and professional development events through other organizations' e-newsletters and websites. And at the trainings or networking forums themselves, we promote our trainings. And because we've been around for a long time, some of the promotion is word of mouth through CHWs and through their supervisors, which is probably the best way to get folks to come to our training. If they feel it's a good training, they'll tell other folks who they know about the training, and managers who feel like their CHWs have had a great experience and are better workers, they'll also come through. They'll also send more CHWs to our training programs. One of the biggest challenges is helping CHWs complete the program. So like I said, the COEC program is offered 3 times a year. So if they miss a session, they have a couple other opportunities to make up those sessions. We do a lot of follow-up with the CHW participants to get them to complete. So what we do is we give them a printout of their training record and what they need to complete. We give them a schedule about the next trainings. We send them email reminders about the date for the missed session. And if we haven't heard back, we do a lot of follow-up by phone to get them to complete the training. Another key piece that we found is we established a training policy agreement, which spells out the expectations of participation and completion of the program. It talks about a cutoff time, which I'll talk a little bit more about. And we have both the CHW and the supervisor sign this training policy agreement as a part of the registration process, so that the CHW knows what the expectations are, knows how to register. The supervisor knows has approved the CHW to come to the program and is committed to supporting that CHW to complete the program. I think sometimes CHWs are pulled from training because their agency is short-staffed, or they all of a sudden have too much work at their agency. So this is a way to get the supervisor to support them in completing the program and freeing up their time to complete the program. The other thing I wanted to say that's worked for us over the years with this training policy agreement is to stay consistent with the training policies that you establish. So one thing we found too is that we have our training start at 9:30 and we give people a 15-minute grace period. And after that, so they can come up until 9:45, and after that, they can't come into the training. They're going to have to make up the training. If they leave early, they can't get credit for the training. 15 minutes early before the end, they can't get credit and they have to make up that training. And what we found was people were arriving, almost half an hour late, or leaving, like an hour or 2 hours before the end of the training. And so this, again, commits them to that 64 hours or the 80 hours that they need to complete the training. And I would say that, and in one of your handouts, we have the policy agreement for you. I would say also that staying consistent is really good, because if you make an exception, everybody is like, well, you did for this person, why don't you do for that person? And you start to get into a frustrating CHWs. So I would say staying consistent about your policies is the best policy. Okay, so I'm going to talk a little bit about trainers and recruiting trainers and how to work with trainers. Our key, again, to success in ensuring high quality training that meets CHW's needs is hiring great trainers. So we also provided another handout for you on a recruitment process and working for trainers, but I'm going to walk you through a little bit of that. So how to recruit. We have the other thing, I just back up and say, the other thing we have is about a pool of 15 to 17 great trainers that come with a variety of training styles and make the training interesting. So what's worked for us with recruiting, we talk to a lot of other trainers and training coordinators and staff from other programs and ask them for recommendations. We also go and try and observe trainers at conferences or other training sessions. We first go through a screening process where we'll meet with the trainer either in person or by phone, have asked them questions about their training experience, what they train on, what their expertise is, how they train, who they train. We also ask them for a resume and outline, and if we can, get a sample of an outline or presentation slides from a previous training. So our selection criteria is the following. We're looking for somebody with excellent facilitation skills, experience working as a CHW and training CHWs. We look for trainers of color who reflect the CHW participants. We're also looking for trainers who understand and practice adult learning methods and principles, have expertise in that particular content area, and then are willing to collaborate with the CHEC training team around the training. So development, letting us observe the training, and then debriefing and talking about what changes need to be made in the training. Our curriculum development is we ask the trainer, once we've selected a trainer, we ask them to develop an outline and slides and have them send that to us ahead of the training. We'll review the outline and give the trainer feedback about the training and maybe have them make some revisions before they actually do the training. And then if it's a new training, if it's a new trainer, we will sit in and observe the trainer delivering that training and then do a debrief with that trainer. And the new trainer, we usually spend either a half an hour with them. We review the participant evaluations and discuss the suggestions or comments that CHWs have had about the training, as well as give the trainers feedback. I've found that it usually takes a new trainer about 3 times doing the training before the training really flies and is a great training. So what are what comes up as challenges? There's a lot of challenges, but here I just wanted to highlight a few. One is there's great diversity of the backgrounds of CHWs, educationally, culturally, and linguistically. And that presents challenges to the trainer in terms of the kind of trainings that they provide. It also is challenging for managing the group dynamics. And one thing that's worked for us is that we work on establishing or discussing communication guidelines or ground rules in the first session or in the orientation and have CHWs agree to those. You can also add, we have our own, but you can also have CHWs add some that work for them. So some of them include minimizing side conversations, respecting each other and our cultural and linguistic heritages, listening to the person speaking, respectfully disagreeing. And then we have one on smartphones, which is to turn the smartphones to silence or vibrate and put them away. But that still remains a challenge to us, and we're still trying to work out how to manage smartphones. It's sort of changed over time how people use them. One of the other things, so we established the communication guidelines, and then trainers who are in charge of managing the group dynamics can remind participants about these guidelines if there's side conversations going on. Another thing that works too is moving the participants around for group activities. A lot of times what happens is folks will sit with each other and they'll remain together as a group throughout the whole training. So breaking them up and having them go to different tables and work with different participants. Another thing that happens is sometimes there's one or two people who are the first ones to speak up all the time. So you can have a stand down, stand up kind of communication guideline or rule, which has somebody say, oh, we've heard enough from you. You know, we need to hear from some people on the rest of the group. Sometimes we have a program manager who really takes care of the day-to-day issues that come up and runs the training programs. And sometimes that person has had to step in and resolve conflict between CHWs in the training. And again, some of it's the guidelines have helped us sort of manage those group dynamics, particularly when something happens where there's a conflict in the group. I already mentioned assisting CHWs in completion, but that's a big challenge too. We have another person on our staff who really works closely with the CHWs and their supervisors to complete the training. So lessons learned. Lessons learned. One thing that I feel like I can pass on to anybody interested in doing CHW training is to pay constant attention and care about the CHWs, the trainers, and the training itself. Really be invested in the success of the CHWs going through your training program, as well as the trainers. We spend a lot of time with both of them. And I feel like sometimes you can't rest on your laurels or your reputation. The training is very dynamic. Even though the structure can be established in the curriculum, there's always tweaks to the training or tweaks to the way the structure goes. And I feel like what's worked for us is you're only good as your next training. So you have to stay engaged in what's happening and be very invested in making sure that the quality stays high. The other thing is making feedback an essential part of your training program. So we spend a lot of time with feedback, and we listen to CHW's feedback. They have to fill out evaluations at the end of each session. We review that feedback with the trainer and encourage the trainer to incorporate some of the feedback into the training. We also will sit down, even though trainers have been with us a long time, we've also sit down with them and debrief at the end of each session, just to find out how's it going, what went well, what didn't go well, what came up as issues, what may we tell the trainer coming after them that happened in the training that they should be aware of. Good communication with the CHWs and supervisors also a key. So all of our communication, particularly through email, is with the CHW, but the supervisor is CC'd. So they're aware of, if somebody is registered but doesn't come to the training, we know what's going on. And the supervisor, sometimes we found that the CHW registers, but they may have left the organization. And so adding the CHW to your communication helps us kind of work with the CHW as well as the supervisor to figure out what issues are going on. Or some people may have got a family emergency. They may have, had a car accident. Number of things come up for people in the training. And then what I also feel is important, and we've created sort of a community of CHW learners, and we've created other opportunities for learning and professional development. So we have lots of other trainings that we offer CHWs as well as their supervisors. We also have had CHWs who've taken the core competency training 5-6 years ago that are still in contact with us. They may come back for a training. They may come back for a networking session. Some we've recruited them to be trainers in our core competency training programs, or they come back and do networking forums. So we feel like we've stayed connected with the CHWs who've gone through our training. They feel that CHEC is sort of their home or their space where they can get a lot of learning and resources and professional development support from. And that's it for me. Any questions?
Okay, so we have a question from Lana. She would like to know, do you collect information on retention of these trained community health workers, retention on the field? And is there difficulty in building a permanent workforce?
Great question. We don't really, we don't have information on retention. You know, we have records in our database of CHWs who've gone through our trainings, and sometimes they go to a different organization. And it's only through them telling us that they've changed the organization that we changed their contact information. So sometimes our database is a little outdated with information of CHWs. Some leave the field completely, but we don't really track that. All we can do is that track what their trainings and what they've taken with us. And we try, for the trainings, we try and get folks to a 85 or 90% completion rate, at least of the core competency training.
Okay, great. And Sherelle says, very good presentation, Peggy. And thank you, everyone. Thank you for attending. This concludes today's webinar. As I mentioned earlier, please be sure to download the handouts provided by our guest presenters. Also, the webinar evaluation link will be sent to you via email within the next hour. The evaluation link is also available now on our website at causeengagement.com. All evaluations should be completed no later than 5 p.m. Eastern Standard Time on Monday, March 25th. And check back on our website next week for a recording or the slides of the webinar. Thank you, everyone, for participating. And if you have any additional questions, you can always email us at info@causeengagement.com. And I'll make sure that Alisa and Peggy have access to those questions and so that they can respond to you accordingly. And then also, Peggy, how can people get in contact with you?
Yeah, I forgot to add a contact information slide. So you can contact me at Hogarty, HOGARTY, at bphc.org. That's Boston Public Health Commission, bphc.org. Or my phone number is 617-534-2396. 617-534-2396.
Okay, really quick, Peggy, I'm sorry, we have 60 more seconds. We have a question from Venus. Venus says, I have my own public health nonprofit organization. What do I need to do to become a community health worker? Should we have her maybe contact you? If
Sure.
You can answer that if you can within the next 30 seconds or so. But Venus, feel free to contact Peggy or also Alisa or myself.
And just quickly, I mean, if you want to get in, you know, you can apply for certain jobs, but also volunteering is a good way to try and start to create, you know, your career experience or work experience as a CHW.
Alisa, do you have anything to add to that?
Am I on?
Yes.
I'm sorry. I'm like, is this mute thing still on? I'm sorry. What was the question?
The question was, what do I need to do to become a community health worker? And Peggy's last suggestion was to, one thing is to apply for jobs, but also volunteer in the field. And I wanted to know if you had anything to add to that.
No, those are perfect. Volunteering is one of the things I teach my students. It's such a great networking opportunity. Go to trainings, free trainings as much as you can. Just be around community health workers and public health in general, and let people know what you're seeking.
Okay, perfect. And again, we're going to close out the webinar because we want to be respectful of everyone's time. We said that we would end at 2 p.m. Eastern on the dot. So it is 2 p.m. Eastern on the dot. Again, email any questions to info@causeengagement.com, and I'll make sure that those are routed to either Alisa and or Peggy. Thank you very, very much. Have a great day.